Yeah.
All right, everybody. 2 out. We're good on the volume? All right.
Yeah, next week.
So
Next week,
couple of
we got.
so if you didn't see in the news today, came out, craft freedom
First degree.
was given.
Next Wednesday.
The court ruled in their favor, so their case will proceed. So if the barrel limit doesn't get fixed in the General Assembly, it may get fixed in the courts. So let's hope that works out for them. It would be a nice thing to have that go through. I'm just going to go through a list of events. Students House has a polling lunch tomorrow. The NNO has one of their Community Voices events. That's tomorrow at 7 p.m. And that'll be on public schools and funding and public school teachers. This weekend, the LPC has their state convention. I mentioned that I know you all know, but quite a few of you are riding out for just Saturday. So if you're not going and it's of interest, consider it, and I can point you to who can maybe give you a ride if you just want to spend the whole day there. Most of the stuff, most of the events and work happens on Saturday.
It's only 5 miles.
What else do we have? Next Friday, the Salvation Army is our monthly charity event.
Tuesday, the forum. Tuesday, the LGBT forum. Remember?
Oh, yeah, that's right. So that's Republican
GOP
headquarters on Tuesday. Patrick will be on a panel for LGBT
Hillsborough
issues.
Street.
And then after the Salvation Army charity event, the LGBT Center has their open house. That's on Friday, the 25th in May. So they'll have all that. The last two events real quick, 23 June, we have Robin Kerner. As I mentioned before, we had so many libertarians in Wake County running for office that we attracted some national notice. So that is first and foremost for Wake candidates and staff supporting Wake candidates. So if you'd like to go, please try to let me know in the next 3 or 4 days before I open that up to others from across the state. So if you have Saturday, 23 June free, that's almost a whole day event. It'll be like 9:30 to 4:30 at Time Shooting Academy. They have a VIP lounge in the back. It's about 20 to 25. It'll be great. So that is just about everything I have.
Hey, aren't we doing what's the college? You're supposed to have something of this week, wasn't it? I like that lunch. I'd like to go back.
And basically, it's going to be talking about the racist roots of school vouchers. School vouchers were started to allow white kids to go to school so they didn't go to school black. That's basically the history. Similar to the history of marriage laws and gun laws. So you may want to, if you don't already subscribe to the John Locke newsletter, you should, because they always have good speaking. And you can watch it online.
All right. Now we get to our main event. I met Dr. David Fitzpatrick, actually working a polling place all day for Olin Watson. And as you guys know, we bring in people from the right, the left, and what have you. And through the course of that conversation, we talked about publics and zoning, a variety of other issues. And we got onto this topic. And I remembered as we were looking for speakers, Dr. David Fitzpatrick would be fantastic to have at this event. So with that in mind, it's all yours, sir.
Great. Thanks for having us. We met when I worked at the polling station, started talking about what I did. Some background on me. I work at NC State. I teach at NC State 27.5 and their full-time equivalent. So I did that. I teach in the Department of Social Work. Teach classes in addictions. I teach class in addictions, research methods, hunger and homelessness, things like that. I taught a class in American Family Therapy, Finding University, so I taught a couple different classes. The letters here, why do people have letters behind that name? It makes them feel important. But it's insecure. They go ahead and explain them too. So I'll explain this thing. I'm what you call a licensed professional counselor, so I do some counseling, like I know counselors for money that folks really need. I'll help them. I'm a licensed clinical addiction specialist, and then I'm a certified rehabilitation also. So I did some of that on the side. I also work at IBM. slide. You'll notice on that first slide, I used some words like addiction and crisis. And we're going to talk about those words because sometimes people have difficulty with them. I have difficulty with one of those words. Why is this important to you overall, society overall, as well as why is it important to you personally? I presented this first to insurance examiners and said that we have a lot of substance use and leads to high jailings. It leads to people having a propensity towards crime. And we have a lot of other, what you might call societal ills, which come along with that. You will run into someone with a substance use issue. You probably have already. We all know buildings, we all know things like that. You will also run into folks, if you haven't already, who have substance use issues with opioids. I'm quite sure of that. The difference between an opiate and an opioid is an opioid includes, does that mean?
Nope.
Opioids include all those synthetic drugs that are coming along, including the fentanyl and other things. So I might be too close to this. There's a huge focus on opioids in North Carolina and hopefully all over the U.S. Josh Stein is getting into it big time. That governor is getting into it big time. Really, there's a lot of attention paid to that. But one thing I want to bring up is that's not all we have. There are a whole bunch of other substance issues we can look at. We'll briefly discuss those as well as this opioid issue. As I said before, opiates, specifically opiates and specifically opiate withdrawal is associated with a lot of crime. We've also found that a lot more individuals, or I should say a significant amount more individuals, leave rehab programs against medical advice if they're using opioids as opposed to other substances such as alcohol, such as crack, cocaine. Go to the next slide. I hear the word slung around a lot, crisis, epidemic, when people talk about opioids. And I've always said, why are we using these words? Why are we calling it a crisis? Why are we calling it an epidemic? I've spoken to a couple of people before, but does anyone know why we would choose to use those words? Politically, it's good. Yeah. Call it a brain disorder. And guess who's dying? Guess who's getting addicted? Why do you think we're calling this an opioid epidemic, an opioid crisis? Because it's happening to white people. It's happening to middle-class white people. It wasn't an epidemic. It wasn't a crisis when we had this crack cocaine. Was it back 20 years ago? I didn't hear that. Lots of people. Back then, all of a sudden, it was a criminal issue. That was a criminal issue. It wasn't a health issue, but now it's hitting a different population. All of a sudden, we think it is an epidemic. We think it's a health issue. We're looking towards healthcare to solve this issue rather than mass incarceration, which we were doing 20 years ago because it was a different demographic. And I see it in my neighborhood. I see it in the shelters I go to. I see it where the whole crowd is changing. We've got a different demographic of people using it. Alcohol's still here. Crack cocaine is still here. We have new drugs coming all the time. Fentanyl, you may have heard of. There are drugs like Flacco, Crocodile, these things that people outside of the industry haven't heard about. And I hear about new drugs all the time. People say, did you read an article about such and such a drug? A lot of them are synthetic drugs, and a lot of them are being imported. So we've got the synthetic and the natural drugs. Long and short of it is you can feel however you want to about addiction, about substance use. You can feel like it's a disease. You can feel like it's a moral failing, whatever you'd like to. But we need to pay attention to this because it is breaking down a lot of people. A lot of people are dying from this. The way I like to look at it, I call it a bio-psycho-social spiritual disorder. So we have elements of biology, psychology, spirituality without a doubt in there, and sociology. So we have these issues all coming together into one. Some people might have a higher propensity to use substances, others might not, others might get in a bad crowd, so we can say whatever we want about it. It really matters very little, I believe, how you describe this, what you describe as, what words you use. We just need to know it's around. I always give out my cell phone because, as I said, you will probably know someone who is affected by this. If you want to call me on my cell phone, call me. Write it down. That's no problem. Get my number from David, whatever you need to do. You will, I'm pretty sure, find someone already affected by opioids. So some data on this opioids. This was compiled by the Division of Public Health, the Injury and Violence Prevention Branch. Next slide. Here you see the drug overdose death rate. What we call opioid addiction is unintentional poisoning, because it is in fact poisoning. So we look at this, find medication and drug overdose. You'll notice right around probably 2011 it started going up considerably. Next one, please. What happened is in 1989 we decided that the fifth vital sign essentially was pain. So doctors were told, hey, you need to start looking at pain as a fifth vital sign and addressing that pain. And various articles came out suggesting that opioids were not highly addictive. That came out, so doctors started freely prescribing them, more freely prescribing them. I'm not suggesting to you that that is the only reason we have the crisis, or we have a lot more opioid use, but it is one of those. When it was designated as a fifth vital sign, we were told, or the doctors were told as a profession, to start looking more towards pain and pain management. Here we see substances contributing to unintentional medication and drug overdose deaths. Once again, 2010 went up considerably, but you'll see it isn't, it's crack cocaine. Crack cocaine was going up too, mixtures were going up, synthetic narcotics were going up, and also the opioid pain medications were going up. I think we can go to the next slide before I ask the question. This was recently put together, and this shows us essentially where we're dispensing a whole bunch. As you see, we're dispensing a whole bunch of opioids out in western North Carolina. Also, we're losing more and more people here. As you can see, it's 12 or so those rates per 100,000. So that was put together. Let's play a guessing game. Where do you think U.S. is the highest opioid problem? So where in the U.S. do we have the most problem, the highest percentage of people?
West Virginia.
Who are using West Virginia, I heard. Suburbs, San Francisco, the very highest. Let's pick a city with the very highest use.
DC?
DC. How about Wilmington, North Carolina? Look at the next slide, if you would. The next one after that, we're going to review this one. So this should show us the top 25 cities with the most opioid misuse. Number one, there we go, Wilmington, North Carolina. It's amazing. I don't know why people go down to, well, obviously go down to the beach to get high, but it's just out of control. Of course, you were right, or it's a West Virginia. It's kind of spreading more than West. Actually, West Virginia doesn't have any of the highest 25, probably pretty small cities. But we've also got down here in Hickory, North Carolina, I think. We've got Jacksonville, Fayetteville. So North Carolina has 4 of the cities with the highest misuse of opiates. Can we go back one? Back to this is just more unintended medical deaths. Once again, we've got it here and here in North Carolina. So more statistics, opioid deaths, hospitalization. So if we've got 4,000, 8,000 here prescriptions for opioids, 7 million people we have 349,000 residents responded to misusing pain pills. 3,515 emergency visits. 2,600 hospitalizations, and then this 2014 number is 913 deaths. That's pretty significant when you're talking that number. It is a volunteer down in healing transition, so we have to probably lose one person every 2 to 3 weeks down there. But symptoms, who knows some of the symptoms of using opioids? I'll tell you, one of the tricky things with opioids is that individuals using opioids, they tend to act more normal. They reach that homeostasis where they're acting normally when they have their drug. When you find irrational behavior is when you're moving towards away from the drug. When you start getting dosing. Individuals get dosing and they know that they'll often need to steal and do things they don't want to support their habit. So individuals who are not, you ever see someone like they do in my class, is sitting there and their head starts nodding. That's a symptom of pinpoint pupils. Pupils tend to dilate really small beyond the age. Poor coordination, all these are. Here we have a couple of pinpoint pupil flu-like symptoms. So when an individual quits using opioids, unless they have medicine to help them with their withdrawals, it's like they get the worst flu ever. So for 4 or 5 days, they're going to have bone aches, runny nose, and that is a symptom of opioid withdrawal. It's a really bad one. It's like the worst flu you've ever seen. You see these abandoning responsibility spurts, sleeping more or less than normal, mood swings, euphoria, but you have those in most substances, and guess what? That's why we get high, because we like some of these things. You know, we like the euphoria. For a lot of people, they enjoy getting high, and I say to my students, that's how it starts out. Individuals like to get high. Some of them do it successfully, some of them don't successfully. Others don't. Things can get nastier, things can get uncomfortable, and then towards the end, if you have that true addiction, I see you look towards jails, institutions, and death, it can get real ugly. For some individuals, it doesn't mean everyone is going to get that way. We also see that some people can use substances successfully, some people can drink successfully. I believe many people can successfully smoke marijuana. Some use some cocaine on the weekends if they choose to. They can do it successfully. Other people don't do it so successfully. It gets very, very messy. But these are some of the symptoms of opioid abuse and also the withdrawal symptoms. Anyone heard of naloxone, Narcan? Yeah. I see that as kind of a miracle drug. Once again, this is controversial. A lot of things we're talking about are controversial. Long and short of it is naloxone is a drug, a medication that could be administered when someone is going through an overdose, and it miraculously reverses the effect of an opioid and brings them back to life. So an individual can be literally slumped, passing out, going blue, barely breathing, on the cusp of death, and you can administer this naloxone to them, and they will come out of that. I think that's a good thing. I don't think we should let someone die just because they made the mistake of using an opioid, using too much. Yes, please.
Possible dumb question. Is it similar to methadone?
No, it isn't. It's more reversible. We will get into what is similar to methadone.
Okay.
Because there is another great medication now, what I consider to be a very good medication, which is similar to methadone, but isn't. You don't have to use for quite so long. Yeah. So many police forces carry this opioid reversal kit. I have one in my car. I have one in my office at NC State, and I have one at home. And I can use it. The Attorney General, I think, of most states issued a standing order about 5 years ago saying anyone can have this naloxone. You can administer it as a nasal spray. You can administer it as a one of those, what do you call them, the
Injector,
type things.
self-injector.
Or you could use shots. I've got a couple of hypodermic needles and a couple of vials, and if I saw someone who was on the cusp of death, you could administer this. You know what? This is my boss off, but I say I'm not a real doctor. I got a PhD. I'm not it shows you, you can tell if someone's turning blue, if their respiration is going down. And if you administer it and you make a mistake, no big deal, because it won't help you, it won't affect you if you haven't been using opioids. There is a standing order, so anyone can get this. They sell it at Walmart, Walgreens. They distribute it for free around campuses, things such as this. On the other side of that, you have some individuals who say it shouldn't be available, because if you make it available, someone's just going to try and get as high as they possibly can, knowing that there are no negative ramifications. So you might have to bring people back time and time again. One thing that has happened now at Healing Transitions, which is a homeless shelter with a long-term substance use treatment plan, they have hired 2 individuals who go out anytime there is a reversal with naloxone and give immediate counseling and offer help to the individual who has been brought back, which I think is a very positive thing. So that's naloxone. As it says up here, the Good Samaritan law says there is no, if you mess it up, there is no ramifications to you. You can do it, you can dispense it. So laws are in place to giving immunity. The question was, is this kind of like methadone? No, it isn't like methadone, because it negates the impact it'll give you on time. Methadone is a medication that's probably been around 40, 50 years. And methadone is an opioid. It is an opiate, just as heroin's an opiate. Prescription pills are an opiate, but it's a safer opiate. It's given to individuals. They have methadone treatment plans, and many people use it for long-term maintenance plan because it's a slow release opioid. You don't really get high, but you will avoid withdrawals that is so perilous for those who are using. There's another medication that came along about 10 years ago that's called Suboxone. Suboxone is a medication which can be given. It takes away the withdrawal symptoms and it helps you withdraw safely from opioids. I suggest to you that this Suboxone, or some people use something called Subutex, and as a matter of fact, that you asked a question, Suboxone does have a little bit of naloxone in it, so you can chop it up and use it to get high, but it's a combination of Suboxone and naloxone. And that I see as a good thing to use for a short to mid-term treatment plan. I don't think, this is my personal opinion, I don't think we should be using this Subutex and Suboxone as a long-term treatment plan. Maybe 6 months is difficult to get up, but once again, it is an opioid. Many people think you're substituting one drug for another, and quite frankly, you are, but you're substituting a safer drug for a less safe drug. You're substituting a drug which is prescribed for one that is not. Because if you get a hot shot of heroin, you're going to die. And then you die young. Did that answer the question?
Absolutely.
Good. If you've got, or maybe more than you need. And anyone, if you've got questions, please ask. Let's go to the next slide. Naloxone reversal. So there are a couple of counties. We've got high naloxone reversal rates. We've got others where we don't have any reversals with naloxone. I think police departments, I think emergency responders should carry naloxone, and that's just because I've seen so many people die from it. That's my opinion. We can debate that and discuss that afterwards if you'd like to, because there are different opinions on whether we should be using naloxone, whether we should be using Suboxone, whether we should be using methadone. What does recovery mean? So now we're moving towards recovery. Someone can truly get into recovery. What does that mean? They pay their bills on time. That's a good thing. 50% of people pay their taxes when they never have before. Plan for the future. Involvement in domestic violence goes way, way down. Obviously, if you're not high, if you're not drunk, you're probably going to get less domestic violence. Participation in family activities increases. We see so many times when it completely rips apart families. That's why I believe that treatment is so essential, because it helps not only the individual, it helps the children coming. It may be the one time when we can break that destructive cycle. Someone has to stop this continuous poverty, this intergenerational poverty. It could happen, and some of the intergenerational use of substances, because we see that an awful lot too. Frequency utilization department, emergency room departments go down. So you have less people going to the emergency room. I did some research at Wake Med, looking at people going into substance use disorders and looking at the insurance that they were on. We looked at TRICARE veteran insurance, we looked at private insurance, we looked at Medicaid, we looked at no insurance. Who do you think had to stay in the emergency room for the longest period of time before they were assigned a room? Someone said no insurance? One more time. It was the veterans, because we don't have veteran beds. We might have a high percentage of veterans, but veterans stayed in the emergency room waiting for beds significantly longer than anyone else, including those individuals with no insurance. Yep. Yes. Yes. No, I don't. I don't serve in those regions. I'm not there. The question was, hey, we see a lot of this around Army bases, and yes, we do. We used to see it in Vietnam back in the day. I haven't seen it a lot. I do know that substance use disorders are way higher in that, particularly those that suffer from PTSD due to traumatic situations and assigned overseas. Yeah. And you've got to wonder, if you see it's there in Jacksonville and Fayetteville, you got to say, why isn't it? Could be a concentration of young folks. Could also be a high level of PTSD. You seek to take something, you might take that. Self-medicate, yeah, because you can't. The VA sure isn't. They're starting to do better, but the U.S. overall is not providing. We're throwing people in prison instead of giving them help. We would save one hell of a lot of money if we offered treatment rather than offering punitive measures. It costs about $90 a day. I think sheet someone in prison. It costs $40 a day to do in treatment. I can tell you more afterwards. Maybe we'll speak individually about the work they do in healing transitions. I've got a slide on that too. So these are all the things that get better. A lot gets better when one recovers from substance use disorder. We discussed methadone, subtext, stuff on those things. There are other things that aren't used very much. This is a pyramid and a campusate. Anyone heard of abuse? It's for alcohol. You take it, and you drink alcohol after it, you get extremely sick. We don't see that used much, but occasionally. For cocaine, there is no FDA-approved medication for that. So that's one issue we have with cocaine. There has been a lot of research there, and I would say cocaine, powder cocaine, and crack cocaine. No, they're not. These all have to be prescribed to you. And not only that, Suboxone, which is overall buprenorphine, has to be given to you by a specialized doctor. It can't be given to you by a family practitioner. You have to have a special psychiatric MD prescribe it to you, and that MD can only have a certain patient load. I think it's up to 50 a month of individuals when in fact. So what makes it difficult for that treatment to come, or has always been rather difficult. So a few things: individuals who use illicit drugs are more likely to commit crimes. That's pretty much obvious. Drug use is indicated in 3 types of offenses: offenses to get things, offenses to keep using, and violent offenses. And also those with drug dependency are more likely to be arrested for explicit crimes trying to get things. And you will find that a lot with those folks. Folks do not like to get those things, so they will steal. They will steal from their family. They will steal from those closest to them. It's just a fact. It's not good, but getting those things is not very pleasant at all. So a few more, you can read up these on your own if you're interested. But the total correctional population is estimated to be 6,900,000, and then we deal with those individuals coming out of prison afterwards, and we really don't have much of a way for them to work. So let's go to the, here we go, 14% of state and 17% of federal prisons report having received drug treatment since admission. That's kind of a low percentage when you figure about 80% is probably in there because of drug crimes. So this was some of the crime statistics showed that the odds of claiming were between 2.8 and 3.8 times greater for drug users. It talks about specifically the highest was among crack cocaine users, 6 times greater, heroin users 3 times greater, and powdered cocaine 2.5 times higher. It's also statistical association between recreational drug use and offending. How are we doing on time?
You're about half hour.
Yeah, okay. We'll move to the next slide. Again, for help, so where can we get help, particularly in North Carolina, particularly around here? I told you about one program, Healing Transitions. Has anyone heard of Healing Transitions or the Healing Place? Good. Yeah, it's down just by the farmers market. They have a men's facility that has 200 beds. They have a women's facility out on 70, which has 110 beds now. It's packed all the time. It is a non-medical program, so it's a non-medical detox. You don't get meds to help you through your withdrawal symptoms. It's a long-term program. It lasts about a year to a year and a half. It's completely free. It doesn't accept insurance. They don't, no one who is in there pays, and we're taking individuals who are homeless, have been homeless. And homelessness is a continuum. You have those individuals who have been living under a bridge for 10 years on one end of the continuum. Then you have the young kid who's going from couch to couch on the other end of the continuum. So we do Healing Transitions takes a whole bunch of different people. The statistics there are if someone finishes their program, the chances of them being sober 1 year later is 74%, I think. So it's a real, but it's a long-term program. It's difficult, and it's difficult to get through. Crisis and assistance centers, that we have those in Raleigh and Chapel Hill. If someone needs help, they can go there and take individuals, and they've had an immediate admin, whether they've got insurance or not. So Wakebrook, UNC Wakebrook, I did some work there. Fellowship Hall in Greensboro. Private rehab programs. So if you ever need to know about any of those, I can help you with those. Wilmington Treatment Center, a little further away. Once again, that's my cell phone number. You can find me at state. If you know someone who needs help and just need resources, need someone to talk to, let me know, because this is what I do, because I enjoy it. Like I said, I know. It kind of sounds bad, because I feel useful doing it. It makes me feel useful. I do it because it's needed. I can do it because I can do it without getting paid for it. Everyone in my neighborhood knows I do it, so I get a call from up the street, down the street. I get lots of calls. So if you need assistance, advice, somewhere to go, just let me know. This is the last slide. Are there questions, discussion?
Yeah, we'll pass the microphone around. So people can
Differences,
hear
yeah,
the questions. The one question, I'll start real quick before we go around the horn. You mentioned healing transitions being free. Is that privately funded?
Yeah, there are 3 types. It costs $3.3 million to run healing transitions each year. 1.1 million of that is provided by the ABC Board. The Alcoholic Beverage Commission of Wake County provides 1.1 million. Wake County provides 600,000. Wake City provides 100,000, and the rest is private. Yeah, so about half is private money, just private donations, charity.
Thank you. So I also have a question about healing transitions, because 74% is an amazing number, and congratulations for that. But what is the graduation rate?
Yeah, that's exactly right. I'm glad you went there. Healing Transitions doesn't publish that number a whole bunch because it gives you an absolute false hope. You say someone reads 74%, you're thinking, oh, there's a 74% chance my loved one is going to get sober. The graduation rate there is about 12% of individuals finish the program, and that's all 1.5 years, 1 to 1.5 years. That research has been looked at, and I've actually done research and looking at it by age, race, gender, military status, drug of choice, age of first use, things like that. I did my dissertation on that. So it's a way lower number than me. What we haven't looked at, and I used to be chair of the board of directors, that's why I use we. What we haven't looked at is saying, how many of those individuals who left after 6 months stayed sober? How many of those didn't? And that's from a program evaluation point of view. If you say, hey, as many as staying sober after 6 months as a full year, maybe you make the program shorter. And that's particularly true with women, because women complete the program at a lower rate than men. And much of that, I believe, is due to childcare issues. Or maybe, guess what? Maybe women just get it quicker. Maybe it takes 6 months. Maybe they get rid of an abusive spouse and they don't use anymore. So there are various reasons, and that would take qualitative, but excellent question, and it needs to be said because 74 is false hope.
Doctor, thank you so much. So, with a lot of experience being anecdotal, what is your view regarding a non-medical approach versus the effectiveness of a medical approach? What's your opinion?
I think it much depends on whether you can do it. Sometimes what we find is that a non-medical approach, I'll break up the medical approach and non-medical approach into 2 different things, if I may. One of it is during withdrawal, during detox. I think for many, many people, having something to take the edge off, having something to avoid dope sickness is very, very important. And we do find that there is a significant difference, although it be only 5 or 6%, there's a significant difference in detox between those who have a medical approach and those who don't. As far as long-term treatment, it's kind of to each his own. I think if an individual wants to absolutely insist that they need long-term methadone treatment and they can function and be a good father, a good parent, they can be a good member of society using prescribed methadone, let them do it.
Or Suboxone.
Or Suboxone. Suboxone, I would love to say that we have Suboxone only as short-term, 6 months, because methadone can be abused. Suboxone can't be abused. I'll add one more thing. When I was down at ECU getting my master's degree, I had a professor who said, guess what? Let's make it all legal. Everything. Let's make marijuana legal. Let's make cocaine legal. Everything's legal. Let's switch it. It's a health issue. It's not one that's going to be fixed by incarcerated. But we know who's getting incarcerated.
It's not my neighbors who are getting high. They get high, and they don't go to prison for it. But you get, homes down here who didn't have a chance to begin with. People are out looking for him, throwing him in jail, abusing it. So, yeah, without a doubt, if you're allowed to sit, in my opinion, if you're allowed to sit here and drink a beer, I think you should be able to light one up in your own home. That's just me. I know I didn't start out by saying that because everyone thinks, oh, the libertarians, those ones who love to get high. I didn't start out saying that, but alcohol is far, far, far more destructive than marijuana. Cigarettes are far, far more destructive, and they are a psychoactive substance, without a doubt, just as other things are. So it would be nice if everyone could do it without medication long term, but some people can, for whatever works for them. I've seen people move into long-term sobriety with a non-medical approach and a medical approach. So this is whatever works for them.
You're leading right into my question. What is the cost difference between rehabilitation and incarceration? How much cheaper is rehab versus putting someone in prison?
People say it's 7 to 1. So every dollar spent on rehabilitation saves $7 when it comes to societal cost. And there are several things that go into that. That's probably blowing up a lot because the proponents of treatment say that. But what we are looking at is if someone doesn't become incarcerated, they make more in their lifetime, they pay taxes, they don't go into medical help. So it's generally accepted. It is $7 saved for every $1 invested in treatment. I think this is going to be a tough question. He's referencing one of my slides.
Go back one slide, because am I reading that statistically people who use cocaine, crack, commit less crime than people who use opioids?
No, they commit more crime.
Well,
The greatest odds of offending were highest. So the odds of offending are highest among crack cocaine users. I think one of the big differences with crack cocaine, you're going to smoke a rock and stay high for about 20 minutes and then go out for more. With heroin use, you tend to stay high for a longer period of time. And once again, it's a different demographic using. I mean, people with more money, with less need to offend, tend to be using particularly opioid pills. And that's why people switch to heroin, because short term, it's cheaper. Individuals will be doing pills. You can, for an 80 milligram OxyContin pill, you can be paying 80 bucks. So pills get really, really expensive. If you want to get high, if you want to catch an opiate buzz, it's way safer to use pills. Once you start using heroin, which seems cheaper because you get it $10 a bag, shoot up and stay high for a while longer, it looks attractive. Some folks get heroin, they say, hey, I'm only going to snort heroin. You can snort heroin, but then you can smoke heroin, but they end up injecting it. That's where things get really sketchy, really dicey. It's mixed up with some fentanyl and you don't know it. And you can wake up dead, like I say.
Just to follow up on this particular analysis here about, I don't see the alcohol effect. I'm wondering where that would sit. Like, particularly, would it be higher or lower than marijuana?
I can only give, higher than low than marijuana. We know the answer to that. Positively, without. When is the last person you know who died from getting high, smoking some weed? Yeah, not in the history of mankind, exactly. When is the last wreck you saw on the highway? Probably last night, probably the night before. Yeah, so without a doubt. Alcohol and cigarettes are the most destructive substances there is. Positively, without a doubt. It breaks more families. Alcohol breaks up more families. All of the rest combined. And marijuana just doesn't do it. We know that. And why doesn't everyone know it? Why don't they up in Washington say that? Because they like to drink, they don't like to get high, because they're a bunch of old white men making rules for all the rest of us. I say it the way it is. I was on a flight to Atlanta. I was chatting with a guy once about substance use. A black guy sitting next to me, and I was talking to him. I said, you know what? Sometimes I'm ashamed to be an old white dude because I see all these politicians doing crazy stuff up in Washington. He looked at me and he said, you know what? It's better to be ashamed than scared. So you got a point there. Zeets, run a guy. I don't get the rules they make up. There is no basis behind them. I don't understand the spending on punitive measures, or let's say before 5, 10 years ago, the spending on punitive measures as opposed to treatment. And then all of a sudden it's changed and we're looking for money to support treatment. I mean, as much as I hate it, if that helps everyone, good. Let's spend the money on treatment.
My sister is a neonatal nurse practitioner, and one thing that I asked her about was, I know that she deals a lot with babies whose mothers were addicted to various drugs. And she said that the most difficult thing for the infants to get off of was methadone. That they have a far easier time weaning children off of harder opiates than they do methadone. Has there been a study of that?
I don't know of one. However, I will say that heroin and opioids are one of the safest drugs there are. And if an individual comes into the hospital pregnant and they are using heroin, it's very, very often recommended that they are switched to methadone and have methadone throughout the pregnancy. Correct me if I'm wrong in any of these. I'm saying this. We got a nurse here. I mean, that's what you do pretty much, because you don't want them out there selling themselves to support their habit. You don't want them maybe getting a hot shot, but it does take some careful medication management when it's all over. I will tell you one thing, which is getting off subject of it, but it has been proven that there's no such thing as a crack baby, and there is no long-term negative health impacts, which we can say are specifically because of what we heard 20 years ago as crack babies. That's one thing that's been researched. That's another kind of pejorative thing in my mind.
I have a success story.
Good.
I have a success story for healing transition. I have a girlfriend whose son started smoking dope in high school, graduated to prescription drugs, and then on to cocaine. And probably about when he was 19, he put himself into healing transitions. A year and a half later, he got out and he went to nursing school and he worked for Wake Libertarians, helping people.
That's terrific. I'm sure I know. I think I know who it is. I'll tell you one reason I'm proud of North Carolina State, because working at state and also at Healing Transitions, I have the opportunity to see people who finish up at Healing Transitions, and many of them go to Wake Tech and they finish their associate's degree. And some people will say, "Oh yeah, talk to David. He may be able to help you." And we've had at least 5 individuals who have been accepted in the social work program after finishing Healing Transitions and being sober sometime, and either got a master's of social work or an undergrad in social work. We've also got 3 individuals in there now who are in the engineering program after going through Healing Transitions. And I know the advisors, and I say to them, "Hey, if I refer someone to you, they've probably been high a lot in their life, they've probably been homeless in their life, they're probably in recovery. So accept that, and they prove they can do it, and regardless of their background, at NC State, we will take individuals in not just social work at liberal science, but in engineering and other programs if they have had a rough go at it, because they, in my opinion, deserve a second chance, without a doubt.
So, my mother's been on opioids since 2009. The VA basically goes through fibromyalgia.
Yeah.
It's kind of a weird thing. So I do know that the VA has been sending Narcan kits to veterans as of lately. I know about a package mail from the VA, and sure it got the Narcan kit with the instructions on how to use it, achieving so for people who can't get through the VA, don't have these instructions. How do you go to like get to Walmart or something to say, hey, I want to do Narcan, just need to be cool or in a cool area?
You just go and you say, hey, I want some Narcan. Or you can, there is a North Carolina Harm Reduction Coalition. They'll bring you some for free. I'll ask a question. You say your mother is on opioids. That can be a good thing. Just because someone's on opioids, I got the impression that it wasn't a good thing. But, you know, opioids serve a purpose. Overprescribing does not. Long-term use does not. But we are addressing some of those in North Carolina that you can only give 6 or 7 days worth, because it doesn't take long to have some withdrawal symptoms. A lot of people, they start out with fibromyalgia. Another thing with opioids is you start getting used to them and need more and more very, very quickly. And then some of the deaths come from individuals who actually do quit using heroin. Then they go out again and think they can take the same dose or half the dose they took before and end up killing themselves from that. We've had 3 reversals of healing transitions. They found people literally keeled over, blue, barely breathing, and managed to get that reversal. I'm glad your mother got it. I'd recommend you had it. I'd recommend anyone who thinks it could be a risk, of whether it be your kid, whether it be a student. Have it. Why not? Why not have it?
So actually, I have another question.
Please. Yep.
So I have another question. You said that you had 3 individuals who were obtaining an engineering degree.
Yes.
And that's phenomenal. But one question I have is, I know the engineer degrees are, their licenses are issued by the state fire marshal's office here in North Carolina. And they are actually quite restrictive with people with felony convictions. Do you have a partnership with the state fire marshal's office to get exemptions for felonies, or are you working in any direction like that?
I'm not aware of one. No, I didn't know it. I think at least one of the individuals does have a felony. Basically, throughout this world, you're kind of screwed if you got a felony. It's a punishment for life. And that's troublesome to me, just because a kid was doing some dope and had his dope in 2 different bags and got busted for a felony because he was sharing it up with his buddies or something. You end up with a life sentence, essentially. And that's, in my opinion, pretty much disgraceful, because there have been those times I may have shared things with my friends. I didn't get busted, you know. Maybe I took my little share out of the baggie when it came around. So I had 2 bags, and if you the wrong person, you can be told, hey, that's trafficking, and you end up with a felony for life. And it's such a shame, because these individuals can really, really be a credit to society overall, their families and everyone. There are some laws going into effect, ban the box. Wake County was one of the first counties to have ban the box, where you cannot put on a job application, have you ever been convicted of a felony? Government jobs, yeah, you're exactly, thanks for the clarification. So government job, they haven't said it everywhere, but individuals ask me, they go through treatment and they say, hey, we've all got those boxes on there. Have you been convicted of a felony? I practice rigorous honesty, except for in one case. Y'all can guess what it is. If you put it on there, I've got 100 resumes, one dude says he's got a felony, I'd look at it, and many people wouldn't. I don't agree with that either.
So you've given everybody here, you've offered to help. Or anyone here whose families may need help.
Yep.
So I'm going to turn that around and give you an opportunity. What can we do, and the folks who are watching do, to help you do that?
Avoid stigma. I had my substance use issue. People don't get into this field because they didn't. I quit using any substances 14 years ago, not because I wanted to, because I pretty much need to. Get rid of the stigma. If you know someone, if you have experience with it, say, yeah, let's try and get rid of some of that stigma. Go down to the healing place, healing transitions, volunteer down there, go down there and slop dinner one day and see all these folks going through and go, oh man, he doesn't look like a dope head. Oh, he doesn't, because we all know what it looks like. We do practices in our head. You close your eyes and I say, imagine a drunk, and a certain picture comes to mind. It just does. A guy's got an old scruffy beard. He's on the side of the road. But we all have that stigma. I do. Let's get rid of that stigma. Let's talk about it. Let's support those efforts to help rather than incarcerate. And that's so important. Just having individuals. So yeah, I think just talk about it. I'll give a couple of bucks to Healing Transitions. They started a new funding thing. It used to be they tried to get everyone up for, $1,000, $10,000 or something like that. I said to them, why don't you just start? I don't have $1,000 friends. I got $20 and $40 friends. I said, why don't you start this thing where you have to buy a bag for a night? So you pay $40 and that covers a bag for one person for once a month, and they withdraw from you from your account. It's not a lot. You end up getting $500 a year, and that's what I suggested they do. Get a whole bunch of small donations from my poor friends instead of the big ones. Work on the big ones too. I appreciate that question. No one's asked it before, and there's a lot we can do. Just get an naloxone kit if you know someone who's there, because you may save a life. Avoid the stigma, and work with people, understand people, because you know what, I probably might not look like someone who's ever used substances. Many people here don't, but probably many people have, and I have too. So it's got to understand that. I'm staying around for a while afterwards if you got questions.
I'm going to get through the last two.
Please.
For me, it's almost always about policy, so we'll go there. First, some states have expanded Medicaid. Kentucky is a good example. And with that, they actually saw in some rural counties abuse rates and addiction rates rise. How do you combat that while still providing medical care to those who perhaps are uninsured now or what have you? And the second one, in this state, they have a law, of course, where they're supposed to be reporting more, right? The doctors are supposed to be tracked when they're writing too many prescriptions. And that one I know, my father had Parkinson's, and they wrote him a prescription for, I can't remember which opioid, for just 2 stitches when he fell. And of course, he wasn't even complaining about pain. So on your pain scale, it was just the fact that he had fantastic insurance that let that
I've got
prescription
a
go out.
definite answer for the second one. For the first one, I'm not quite so sure about. I didn't know that some of the abuse rates had gone up. I think the rates may have gone up anyway. Expanded Medicaid. Medicaid is abused. Medicaid is big government, but many people really, really need it. So I think we just have to, and I'm in a situation now where my son needs Medicaid. He gets Medicaid for a mental health disorder, and he really, really needs it, but they're kind of tightening the screws even on those who do need it. For the second, yes, we should be tracking prescriptions by doctor. We should be tracking who are getting those prescriptions. I was working at Wake probably 8 years ago, and a guy told me he, within the last year, had been to 60 different doctors.
Jeez.
Yes, 60 different doctors to get his dope. He was doctor shopping, and that's a real prevalent thing. So yes, we should know. We should have, doctors should be required when they, in my opinion, of course, when they are prescribing opioid medications, they should be required to report it. We do have an opioid tracking base. It's only used in about 14% of cases. And it's not to be punitive, it's because if we see these individuals getting prescriptions from all over, maybe we can offer the help. And doctors who prescribe to make a buck, you don't see it a lot, but you see it occasionally. It should be addressed. I think stopped is too harsh of a word because it implies those punitive methods. But we should know where all this dope's going. If you look on that map in western North Carolina, there's no way in hell that people need that many prescription opioids. Just it doesn't make sense, and you're facilitating that addiction, in my opinion. So yeah, track that. I know it's a big government, but yeah, track who's using. How many opioids are being given out by the doctors, as well as where people are receiving it, so you can offer help if needed.
Thank you, I appreciate that. And I know we enjoyed having you here tonight. And come back and actually enjoy the meal without answering bunches of questions.
Thank you very much.
And you'll need that in November because we're going to have a big impact. And we want to make sure you have a.
You might need to pick up a white chip if you know what I'm saying. After this, thanks very much for having me. I'll be around.
And I have those for sale. I have them in my back of my car. If
White
anybody
chips?
wants somebody, the glasses. After killing me. All right. Thank you, everyone.